All right, this is the fourth in the series of the digestive system. We're talking about the peritoneum and the liver. With the topics, we're going to talk about the specific anatomy, the physiology, and quite a bit of pathophysiology. And this is showing a depiction of the peritoneum, kind of like a container that holds not all, but quite a bit of the intra-abdominal organs. So the peritoneum, think of it as a soft container for the intraperitoneal organs. And those include the liver, the stomach, spleen, small bowel, transverse and sigmoid colon, and the uterus. So it's kind of a sac. And you've heard about this sac when we were talking about the cardiovascular system. So why is it helpful to have this sac, this peritoneum, and why is it helpful to have a pericardial sac? Lubrication, cushioning, or both? And the answer is both. Peritoneum, the peritoneal fluid provides some extra as well. Besides the cushioning of these organs, it allows a lot of mobility for the peristalsis of food to move through the gut. And with all that peristalsis, it keeps those coils of intestines from sticking together and causing kinks or knots. So speaking of knots, let's talk about a medical scenario. This is a 58-year-old woman who has an open abdominal surgery for hysterectomy. So she has a removal of her uterus. And the type of surgery is open. So they actually made an incision in her abdomen and were touching her bowel, of course, with gloves, but still. So a year later, she admitted to the hospital for a bowel obstruction. And these images are showing adhesions, these fibrous bands of tissue that will actually kink off bowel. So the upper picture is a depiction of these adhesions. And the lower is an actual laparoscopic picture with a camera showing how these adhesions form. So it's not only with the intestines, but it'll also include the uterus, fallopian tubes, and people will present with pelvic pain from these chronic adhesions. All right, so let's go on to the peritoneum. This is a presentation. This is an actual story of a woman who's 19 years old. This was in a low resource setting. And she had HIV, was unrecognized, and she had presented with severe abdominal pain and lots of abdominal swelling. So the concern was that she'd had a perforation of part of her bowel into her peritoneum, causing peritonitis. So she had a vertical incision, and this is showing her during surgery. The intestines are lying outside of the abdomen, and the surgeon is going through each loop of bowel looking for where it might be perforated. And you'll notice all this stuff on the bowel right here, this kind of brownish stuff, that's peritonitis. That's an infection. It's infecting all these loops of bowel. Here's some more across the way under his left hand. So here, the bowel is lying outside of the incision. What is keeping it from spilling out further? So this, there's an incision under the bowel. The bowel is outside of the abdomen. What keeps it from lying across her abdomen and not spilling into the floor? The answer is it's the mesentery. We'll talk about each of these structures. The omentum is the apron. The peritoneum is what holds everything in place and provides the fluids. And it's the actual mesentery that keeps the bowel from spilling out. The mesentery is actually a fold of peritoneum, and it is attached at the back of the abdominal wall. So all of this is mesentery, and it's keeping everything from falling out. The way I keep track of the word mesentery, I think of it as a mess. So it keeps all the mess in place. So this is a sagittal view showing the peritoneum in blue. And then when the mesentery is a fold of that peritoneum. And so all the purple is mesentery. And notice how you've got specific peritoneal organs. The liver is one. Down here is the bladder. So the uterus is in here as well. But it's the main thing I want to make sure you understand with this sagittal view is how the peritoneum contains these organs and the mesentery is a fold of that peritoneum. So more pathology. This is ascites, is a situation where there's excessive peritoneal fluid. So you can see a person with a huge distended abdomen, and you have to figure out whether they've got ascites or their abdomen is distended from abdominal fat within the omentum. Next question. Failure of what intraperitoneal organ will cause ascites? Is it the pancreas, the liver, or the spleen? The answer is it's the liver. The liver is an intraperitoneal organ, and this is showing the stages of liver failure. It goes from fatty liver infiltration. It can go from that to steatohepatitis, and then it can finally go to complete cirrhosis, where it becomes just rock hard and blood isn't able to flow through the liver. And that develops the situation of portal hypertension. The portal vein is the vessel, which is a vein that carries blood to the liver. Here's another picture. So a hardened liver blocks this blood flow. And this structure here, this blue structure, is the portal vein. And normally blood flows through the portal vein, goes through the liver, and then goes on to the heart by way of the hepatic vein. But with an obstruction, with cirrhosis, liver abscesses, anything that shuts the liver down, this will shunt the blood away from the liver, and the blood is trying to find a way back to the heart. So it develops these huge vessels called varices. And liver, as it can't function, you start seeing splenomegaly, which is a very enlarged spleen. Hemorrhoids. Hemorrhoids is one of the first signs that someone has portal hypertension. Bad hemorrhoids. These aren't just the hemorrhoids from being pregnant. So blood is finding a different route to the heart. The symptoms of portal hypertension include this esophageal varices. So they get these big distended vessels within the esophagus. Splenomegaly, hemorrhoids, all of those things are signs of ascites and portal hypertension. And this is another sign. It's called Kappa Medusa. So it's right around the umbilicus. You get these big distended veins. So this is actually a true story. This happened 45 years ago, maybe. Actually, to yours truly. An intern in July is a dangerous situation. They're brand new interns, and they're overwhelmed and just trying to learn the ropes. So patient came at midnight. It's a 58-year-old man with fever, distended tender abdomen, liver failure, and he needs to have a tap, a peritoneal tap. So he needs to have some of that acidic fluid taken out of his abdomen and checked for infection to decide whether or not he needs to be put on antibiotics. So the intern is going to have to draw off some peritoneal fluid. So now it's midnight. The new intern has no experience doing a peritoneal tap. So the senior resident, is July for him as well, obviously, but he's overwhelmed in his new role. And so he's telling the new intern over the phone just to lie the patient on their back and then feel the abdomen down on the lower left side and stick the needle in and just draw the fluid out of the left side of the abdomen. So the new intern is following orders, and the pathology report the next day comes back as acidic fluid and blank tissue in the sample. So what organ was inadvertently biopsied? Was it the spleen, the liver, or the lung? And the answer is it's the spleen. Remember, splenomegaly. Now, I'll just say this caused a massive stir because sticking needles into a spleen, especially a spleen that's enlarged, increases the risk that that spleen would have ruptured. The patient would have bled out and at the very least would have had to go to surgery for a splenectomy. At the very worst, the patient would have died. So at that time of night, appears that God was protecting fools and small children. All right, so actually, let me just say that they changed the way that they would allow people to do peritoneal taps, and changing of it was doing it with a patient semi-recumbent, so sitting up just a little bit, like in a lazy boy recliner, and then the blood, I mean, not the blood, but the peritoneal fluid drawn off just below the umbilicus. So this is showing the hepatic portal system. Again, the hepatic portal vein down here is taking all the blood from the GI tract, all the nutrition, all the toxins, taking it through the liver and going back to the right side of the heart through the hepatic vein. Now here, the hepatic artery is providing oxygen to the liver cells, but the hepatic vein is taking deoxygenated blood back to the heart. All right, another case presentation. This is a 55-year-old man. He's admitted with alcoholic cirrhosis, and he's vomiting bright red blood. And he's also having blood bleeding so quickly that he's passing blood through the stools. And this blood that comes through the stools is called melonic stools or black tarry stools. It's probably the worst smell ever. Okay, so the usual treatment for someone that has upper GI bleeding is to place this NG tube. This is the usual treatment. So a usual patient comes in and maybe they're worried about a bleeding ulcer. They put an NG tube down and put it onto suction, and that monitors the bleeding. So it tells the medical providers whether or not the bleeding is ongoing or if the bleeding has stopped. So this is the usual treatment for someone who has blood in the stomach. But we're talking about someone that has liver failure. So why is it a bad idea to put this tube down the esophagus of a patient with portal hypertension? Is the answer A, to prevent gagging and vomiting? B, to prevent the NG tube from rubbing across distended blood vessel? Or both? And I hope the answer you'll put is both. These patients will have all these bleeding esophageal varices, and if they start gagging and vomiting from trying to put an NG tube in, you can actually increase more bleeding from increasing the pressure in the thoracic cavity. And also this NG tube can rub against blood clots that have formed on the esophageal varices. So this is what esophageal varices look like along with gastric varices. So this is looking inside, down someone's esophagus, inside the esophagus. And you're seeing all these varices, irregular surfaces. So this is what it looks like from endoscopy. The current treatment for bleeding esophageal varices is either putting a tie around it under endoscopy and general anesthesia, or this is called sclerotherapy, where they actually inject a substance that destroys those superficial bleeding blood vessels. Unfortunately, this is not treating the problem. It's just treating it's not treating the underlying cause, it's just treating the immediate problem. All right, let's go on to another subject. I'm just gonna present another case. This is when I was working out in a low resource setting. This is the story about some passengers that were riding on the back of a open bed truck, and they got stopped by a roadblock. And these were a bunch of guys, desperate guys that dressed up like army and were planning to rob all the passengers. And the driver suspected that they were not true military, and so he started to drive through the roadblock without stopping. So the bandits just started shooting everyone. One person was killed at the scene, and 7 reached the medical facility, in which we only had one operating room. And this is the patient that was shot in the back, an older man, shot in the left flank. And so he had a midline incision for an exploratory laparotomy. And during the case, his blood pressure started falling, and but there was no bleeding in the peritoneum. So where is that bleeding? Sadly, it took some time to convince the initial surgeon that the bleeding was retroperitoneal. But eventually that was dissected out, and that area was packed, and it was found that the bullet was lodged in the psoas muscle, causing extensive bleeding in the peritoneum. And this is an axial cut showing the peritoneum in the red, intraperitoneal cavity is the yellow, and the bullet here is lodged in the psoas muscle right near the kidney. Unfortunately, he had extensive blood loss, and blood was unavailable and he actually bled to death and died 1 day after he arrived at the hospital. Okay, so in summary for the number 4 digestive system, we talked about the liver can be caused by cirrhosis, abscesses, portal hypertension. The peritoneum, how the peritoneum can be affected by infection, like a peritonitis. You can have a ruptured diverticulum, you can have a ruptured appendix. All this will cause peritonitis or infection of the peritoneum. And also the peritoneum provides peritoneal fluid, and ascites will form if there's obstruction to blood flow through the liver, and it forces that fluid to come out of those vessels to fill up the peritoneal cavity. So one of the very most important things for you to remember is this ascites is from liver failure, portal hypertension. Patients with liver failure also, because they're not getting nutrition, they can't get, the liver is unable to create albumin. So with low albumin levels, they also get peripheral edema and even more ascites. Varices are these distended veins as the blood tries to find an alternate pathway back to the heart. And people with liver failure also start developing hepatic encephalopathy because the liver is responsible for cleaning up all the toxins in the blood. And that's the end of that. Hope you enjoyed it. Please leave questions, comments. Thank you.